Okay, so panic disorder and agoraphobia. You can have panic disorder with it, or you can have panic disorder without agoraphobia. So what this is you are having unexpected panic attacks. So you don't know what's going to trigger it, you don't know when it's going to come, you don't know what situation is going to make you start feeling this intense anxiety. So you start to develop a fear of being afraid, a fear of fear. You are freaking out about when is it going to come? What situation am I going to be in? Is it going to be in public? Is it going to be when I'm giving a speech? And you just have intense anxiety about the possibility of having a panic attack. This has to be going on for at least 1 month to have a diagnosis, and then it can also eventually develop agoraphobia. So you are so afraid of having this panic attack that now you're not going to go out into public, or you're not going to go into situations where you are afraid that you won't be able to escape from, such as giving a speech or being in a car. How do you get out of that situation if you're having a panic attack? And in the most extreme case, you may just lock yourself in your home and never leave. So, so you're concerned about being unable to escape or to get help in event of panic symptoms or other unpleasant physical symptoms, falling down, fainting, and such, which is going to cause anxiety. Come on. Oop, there it goes. So these are the typical situations that people with agoraphobia don't want to go to. A shopping mall, too many people. A car, whether you're driver or passenger. Buses, trains, subways. Wide streets, because they're busy. There could be a lot of people on them. So they might go out of their way to go down narrow side roads where there aren't going to be a lot of people. Tunnels, restaurants, theaters, any place far away from home. Being at home alone may freak them out because they're afraid they're going to have a heart attack or something is going to happen to them during a panic attack. Waiting in line causes a lot of anxiety. Supermarket stores, any place with crowds, planes, elevators, escalators. So you get the theme. These are places that either have a lot of people or there's no escape from it. So those are the two biggest situations that freak people out with panic disorders. Now, interestingly, the majority of agoraphobics are female, 75%. I actually had a friend who specializes in agoraphobics, and he said agoraphobics were daddy's little princess, was what he saw the majority of the time. Not all, but the majority of them were sort of spoiled, I don't know if spoiled's the right word, but sort of coddled by their dads, had very protective, very sheltered lives. And his theory was that they just couldn't handle the stress of the outside world, and it caused them so much anxiety that eventually blew up into panic attacks, and then it sort of builds on itself. So now you're afraid of having the panic attack, and so you get more anxious, bigger panic attacks, and now you don't want to leave. So what he did to treat them was he would just take them on field trips. They'd go to a laundromat and he'd teach them how to do their laundry. He'd go to the mall and teach them how to shop without freaking out. And he believed that if these people just had the right social skills, then it would cure their agoraphobia, which seemed to work very well in his program. So cultural factors, this, you could say, the coddled daughter is a cultural sort of thing. But we don't really see many differences between, America and China or Japan or South Africa. There doesn't seem to be a lot of cultural variation. However, somatic symptoms, there is a cultural variation. So they seem to be more emphasized in developing countries than the emotional symptoms. So if an American has a panic disorder, they're much more likely to get a big expression of emotion. Whereas in developing countries, they're more likely to show somatic or bodily symptoms of anxiety. So they don't have a panic attack, maybe a panic attack, but they don't have all the anxiety and depression and stuff as much as they have gastrointestinal distress and the vomiting and all of these physical symptoms coming out. And that's probably because in developing countries, it's less accepted to have emotional expression. So they suppress it, and the more you suppress your emotions, it has to come out somewhere, so it's going to come out in the body. Another anxiety disorder you can get is nocturnal panic, and this is a type of panic disorder. 60% of people with panic disorder experiences nocturnal panic attacks. This usually happens in non-REM sleep, so it is not a part of nightmares. And then mostly in delta slow wave sleep, which is stages 3 and 4. Deep relaxation may be a factor in it. So as you're going to sleep, your body's sort of letting go, relaxing, and people who have panic disorders really like to be in control. I had a professor who said, controlling people are fearful people. So if you're afraid, you want to control what you can control, and that can decrease the fear. So going to sleep, the theory is going to sleep may, in a sense, be releasing control, and all of a sudden it triggers a panic attack. Sleep terrors and sleep paralysis, isolated sleep paralysis, seem to be a part of this. We're not really sure what's going on in sleep terrors. This mostly happens with young boys. Girls can have it too, and adults can have it, but it's most likely to be in a young male. And they just freak out in their sleep, maybe sometimes for hours. Like they're having a horrible nightmare, but you can't wake them up. Trying to wake them up seems to just make it worse, and then when they do wake up, they don't remember it at all. Now, interestingly enough, African Americans are much more likely to get these issues. So African Americans with panic disorder, 60% of African Americans with panic disorder will have nocturnal panic attacks versus only 7.5% of whites. So it's interesting. There's must be, I would assume there's some genetic, well, it has to be a genetic issue that is triggering it. Whether it's like the gene saying you will get more nocturnal panic, or maybe genes saying different levels of hormones or chemicals or brain chemistry or brain wiring. There's some genetic differences between the races with this sort of expression. So treatment. Medication can help. Serotonin drugs like Prozac, noradrenergic drugs, GABA, I always talk about GABA, that can help with any anxiety issue. Benzodiazepines, which will help you relax. SSRIs, I said Prozac with the serotonin. Prozac doesn't create serotonin or give you serotonin. It blocks serotonin from being recycled, and so it can stay in the synaptic cleft longer. However, the problem with medication, and this is true in almost all disorders, is high relapse rates once you stop. So that means it happens again after you stop. And particularly with these anxiety, panic disorders, it's just not really the best way to treat. It's helpful, but it's not a long-term fix. What is much more helpful is psychological fixes. So chances are panic disorder is more psychological than physical. Although, like everything else, don't ixnay the physical part of it. Exposure-based treatments, reality testing, relaxation and breathing skills. You can read more about this in your book, but exposure is really the best treatment in my opinion, where you expose them to the things that are freaking them out. So that's what my friend did with his agoraphobia treatment program. If you are freaked out by the idea of going to a laundromat and doing your laundry, then let's take you there and let's help you to relax in that situation. And then why would it trigger a panic attack again now that you know you can relax there? So that exposure-based treatment is really good. That is exposure, where's my mouse? This one. Exposure to interoceptive cues. Interoceptive cues are the places that trigger, the things that trigger panic attacks. So expose them to those things, they're much less likely to freak out in the long term. So like it says, high degree of efficacy, that means this really works. These things are really good for treating panic. Anxiety disorders are one of the easiest disorders to treat. Generalized anxiety disorder is a little more difficult, but I think that's because there's more of a physical basis to it, and people ignore that in psychologists don't know because they usually aren't taught much physiology, and then doctors are just taught to ignore. If the person has a mental health issue, then just send them to a psychologist who doesn't know about physical stuff. So it's, I think generalized anxiety disorder is something that should be more treated by doctors than psychologists. but it gets ignored by them. So anyhow, it would work better if they treated the physical side of that. So combined psychological and drug treatments, it is no better than CBT, cognitive behavioral therapy, the exposure stuff, or drugs alone. So putting them together doesn't really work, and therapy works much better in the long term. So drugs, helpful short term, not a long-term fix, not really helpful at all if they're doing therapy, and you might as well send them to therapy. To a cognitive behavioral therapist who specializes in anxiety treatments. Okay, that's important. So specific phobias. This is the classic phobia. We're afraid of a dog, or afraid of a rat or a spider. Afraid of something specific. So an extreme and irrational fear. It doesn't make sense to be afraid of. Some people might be afraid of a picture of a spider. Why would you be afraid of that? That doesn't make any sense logically. And it almost always provokes anxiety. And it can be so extreme that even thinking about a spider gives them terrible anxiety. This can create significant impairment or distress, which of course is a criteria for all disorders, but this one can be really bad because they have such panic when they're exposed to the specific thing that is triggering their fear. So this is the diagnostic criteria. A, marked fear or anxiety about a specific object or situation. And I'll talk about situational phobias in a bit. The phobic object or situation almost always provokes immediate fear or anxiety. It could look different in a child. The phobic object or situation is actively avoided or endured with intense fear or anxiety. The fear or anxiety is out of proportion to the actual danger. The fear must be persistent for at least 6 months. It must cause significant distress. It's not better explained by another mental disorder, like OCD, reminder of traumatic events and PTSD and so on. Okay. So you have to have A, B, C, D, E, F, and G. So when you are doing your DSM diagnoses, make sure you're saying if this person has a phobia, a specific phobia, then they meet A because of this, B because of something else, C, and etc. Okay, you go through every single letter in order to diagnose properly. So this is an example of specific phobia: blood injection or injury phobia. So this is probably one of the most common ones. Seeing blood, getting a shot, or seeing or being injured. Decreased heart rate and blood pressure, which will lead to fainting. And this is a very inherited response, so it tends to run in families. So again, there are genetic issues involved in this, usually seen in childhood. I had this when I was a kid. I totally pass out whenever I got like my blood drawn or an injection. And then as an adult, I've had to learn, even today, I'll still think happy thoughts, calm myself down, and I make sure I'm sitting properly in case I do faint, because you don't want to end up falling on the floor. Okay, so a situational phobia is a fear not of an object, but of being in a certain situation, flying in a plane, driving, and this really tends to center around the risks of the situation. The plane could crash, the car could crash, and generally we see it not in children, but in the early 20s is when it's most likely to onset. That's not to say that a child can't get this, because they absolutely can, but strangely enough, it seems to be something that appears in later life. Okay, so what causes these phobias? Usually it is direct or vicarious experiences. So you have seen this happen, or it's happened to you, or you've seen it happen to somebody else, where a dog attacks someone, or you watch the news and see a plane crash, or a movie and see a plane crash. And so information is transmitted to you, either through the direct experience or seeing it somewhere or learning about it, that this thing is dangerous. And so you learn, you've been conditioned to be afraid of something. And phobia treatment, by the way, is so easy to treat phobias that it's the only therapy I've ever seen that will give a money-back guarantee. And usually it can be treated in, 6 sessions is what I've seen. 6 to 10 sessions usually to treat a phobia. It's really easy to treat phobias. So the way a phobia works is you have a part of your brain called the amygdala. Let me see if I can look that up. Amygdala. Come on. I have a very slow computer. So the amygdala is a part of the brain that's job is to control fear. Its main job is to control fear responses. Come on. So the amygdala takes in sensory information and sort of peruses through its files of scary things and sees if this new situation or thing or object is similar to what it has in its files as already scary and dangerous. If it is already scary, or if it's similar to something that's already scary and dangerous, then the amygdala will send a panic response to the body. All right. Amygdala, by the way, means almond in Latin, so it's this little almond-shaped part of the brain. Okay, so sensory information comes in. Let's look at this one. Okay, sensory information comes in. Information goes to the amygdala. The amygdala determines if it is dangerous or not. If it is not dangerous, the amygdala just ignores it. It doesn't do anything. And then that information can go on to the cortex, and the cortex can make a more logical decision about what to do with this situation. But the amygdala, the information actually gets to the amygdala faster than it does to the cortex, a split second faster. So the amygdala can respond quicker. The amygdala does not include logical thought or thinking, period. It is just a reactive mechanism. So it will save your life when a truck is barreling towards you at a fast speed and you'll jump out of the way without even thinking. That's the amygdala taking charge. But it will also, it's also the part that's responsible for you startling in the middle of a movie because somebody jumps out of a closet and it's some stupid situation and everybody else laughs at you because you jumped. And you logically, like a split second later, you know that shouldn't have scared me, but it did anyways. That's the amygdala, and it interpreted that situation as something that you should still be afraid of. Okay, so treating phobias, sorry, those are just so much. Treating phobias involves basically retraining the amygdala. This is not a scary situation. You don't need to react to it. Take it out of your files of dangerous things. So we expose people to it. The most common is graduated exposure. There can also be like immersive exposure. Think the Indiana Jones movie. He had a phobia of snakes and he just falls into a pit of thousands of snakes. You guarantee he's going to get over if he doesn't lose his mind, he'll get over his phobia, assuming he's not bit or anything. So graduated exposure is more likely to take place because it's a little easier on people. So if you are afraid, like I had a student who was afraid of water, deathly afraid of water. She couldn't take a shower, and sometimes even washing her face gave her a panic attack. And her children, they had a swimming pool. Her children were upset that she wouldn't go swimming with them. They wanted to go to the ocean. There was no way she was taking them to the ocean. That much water just totally freaked her out. And so we made a list of what is the least scary thing you can do with water. It'll give you some anxiety, but not much. And she said she could gently splash water on her face from a running sink without being too afraid. And then we went to the next thing. What's the next thing you could do? She could turn on the shower and stand there next to it. Then the next thing is she could stand in the bathtub without being in the stream of the shower. And then she could start putting her body safely, in her mind safely, into the shower until she could stand under it. And then she could go look at the swimming pool. She could stand by the swimming pool. She could put her feet in the swimming pool, get in the swimming pool, and then do the same thing, working her way up to the ocean. And so each step is a bit more scary. And I mean, even talking about some of these things, like talking about getting in the shower with the water, she was just at that level, freaking out talking about it. But we managed to make this list, and it was just sort of a question that a student asked in a class I was actually teaching at a graduate school for therapists on how to do exposure therapy. And so she said she was going to try it. And so next week she comes in and I ask, how did it go? Thinking like maybe she was able to take a shower. And she's like, oh, you'll never believe it. I went to the ocean with my kids and we went splashing in the waves. And in 1 week, at less than a week, because I think it was a Tuesday class, and she went to the ocean on Saturday. So in that many days, she was able to get over her phobia, which is just amazing. And she'd had this phobia for years since she was a child. So the idea is that as you start with the little things, you want to start with something that you can do until it's boring. So splashing water in your face. She could do that, and I told her, do it until you're bored with it. Until you're so freaking bored with it that you'd just rather shoot yourself than keep doing this. And so she said she just splashed water on her face until she was bored out of her mind, and I think she did it for a half hour. She said within 5 minutes, probably, maybe 10 minutes, she had no anxiety, and she just kept doing it until she was super bored. And what that's doing is it's reprogramming the amygdala. The amygdala goes, oh, well, that's not going to kill us. Why were we even panic about that? That's not dangerous. And then everything else on the fear list shifts down a little bit. So now the ocean isn't quite as scary as it was. And then you do the next step, which is turning on the water in the shower and just standing there. And she said she stood in the bathroom for an hour with the shower, and bored out of her mind. And so that's taken, the amygdala kicks that off the list of dangerous things, and everything else becomes a little less scary. So by the time you work up the list to the ocean is way down here, and there's hardly, she said when she got to the ocean, she had no anxiety about it whatsoever by the time she got there. So graduated exposure, super effective at treating phobias. All right, separation anxiety disorder, we'll just go over this briefly. It's not in the DSM-4, it's a new one. And this is just a child who is really freaked out. I mean, beyond normally freaked out. Separation anxiety is normal. The disorder is when it's just excessive separation anxiety. And this often happens because one child I knew with this, the parents told them all the time about kidnappers. Never talk to strangers, stranger danger, which is not a good way of helping your kids. It created a separation anxiety disorder. So the kid was totally freaked out about getting kidnapped. I've also heard of this happening to children who have been traumatized, which makes sense. You could debate on whether they should get an adjustment disorder, which we'll talk about a little bit later, because they're really stressed out. But I think you could make an argument for having an adjustment order and separation anxiety disorder. So anyhow, adults can also have this, which is interesting. So I said it's for kids, but it can continue into adulthood, where they're just really freaked out about people leaving. My sister does not have this to the level of a disorder, but when she was younger, like, she was always calling people, where are you, what are you doing? She had to know. And even as an adult, like, she has an app with a tracking app, and we evolved voluntarily without, nobody minds, but we're all, her siblings and our mom and everything are on this app so that she always knows where we are. She doesn't do anything with it. She doesn't really care. She just likes to open it up, see everybody's still somewhere, and then she's fine with it. I don't know why that helps her, but it makes her happy. So she'd have this minimally, not to the level of a disorder, but it's interesting. All right, then we also have social anxiety disorders. This is one of the more common ones. It's also called social phobia, and this is fear of speaking, when you take a communications class and you have to give a speech. So everybody feels nervous about this. I feel nervous when I stand up in front of a class and teach, even to this day. But this is when it's excessive, right? That's every disorder. It's causing extreme distress, extreme problems in life. So there's an extreme irrational concern about being negatively evaluated by other people. They're going to think I'm stupid. I'm going to do a terrible job. They're going to laugh at me. This can be associated with shyness, but not necessarily. And of course, you get avoidance. Avoidance is part of almost all, I would say all anxiety disorders. You want to avoid the situation that is making you afraid. Now, going back to the amygdala, if you get afraid of something and you run away from it, the amygdala goes, ha, I told you that was dangerous. I told you we should stay away from it. And it hypes up the sensitivity. It makes it even more afraid of that thing. So every time you run away from your public speaking, your amygdala gets a little bit more hypersensitive about it, and you're going to be more afraid the next time. Whereas if you just kept doing it until it was easy, or at least until it was boring and you just got through it, until you were calm, then the amygdala would calm down a bit. Okay, and there are subtypes, like performance only. So some people only have this social anxiety when they are performing, musician, public speaker, etc. Some other people will have it in all social situations. Now, this is fairly common, 12% prevalence over the lifespan, and it is equal amongst men and women, which is sort of interesting. I would have always expected that women would have this more than men, but it's not the case. Usually happens in the teenage years, particularly about 13. And it is more common in people who are young, undereducated, single, and of low socioeconomic status, which makes sense because if you are in those categories, you are more likely to be judged negatively by other people, and so you think that about yourself, but you think it excessively. It's also culturally based, so like Japan has a version of it, Taijin Fusho, something like that, and it's not fear. It's a different type of social anxiety. You are anxious not about yourself, but about making other people uncomfortable, which is a very Eastern type way of thinking. This would not happen in America. But you have social anxiety. You don't want to talk. You're nervous because you might blush, you might smell, you might stutter, or do something else that is embarrassing. But you're not worried about you being embarrassed. You're worrying about offending the other person with this embarrassing behavior. All right, so like everything else, there's a biological propensity towards anxiety, but then there's also the psychological aspect where, you might believe the threatening events are uncontrollable, you can't make people like you. You also may have been taught, this would be a specific psychological vulnerability, you may have been taught to be embarrassed, you may not have been taught skills to help you deal with social situations, and so on. Treatment. Beta blockers is one of the more interesting ones. It's probably one of the ones least likely to do damage to you as well. Beta blockers are heart medication to slow your heart rate down. And one of the things about anxiety is we have this sort of catch-22 where, you get anxious, your heart rate goes up, and then your brain goes, my heart rate's up, so I must be anxious, and you become more anxious, and your heart rate goes up even more, and it sort of spirals up to high anxiety. So if you can keep your heart rate down, then even though you're anxious, your brain goes, well, my heart rate's not up, so I must not be that anxious, and it helps to calm you down. So a lot of musicians and performers will use beta blockers to calm down. Now, too much could stop your heart, so that's dangerous. Could also cause fatigue, memory loss, and things like that, the higher the dose. So it has pros and cons, but it's not addictive. It's a very temporary effect. It's not going to have a lot of long-term issues if you just use it occasionally. So it's one of the more common medication treatments for social anxiety. Now that's only if it's specific, so like public speaking or performance. If it's just general social anxiety, then you wouldn't want to take that all the time. And then you might be given a benzodiazepine, SSRI, and so on. This is the treatment for social phobia. What are we doing here? Let me look at this real quick. Oh, self-exposure. Okay. All right, so exposure to the situation that is making you anxious, exposure plus Prozac, or just cognitive behavioral therapy. So I wish it had cognitive behavioral therapy plus exposure, because exposure is probably part of cognitive behavioral therapy. So obviously therapy is working the best. Prozac is helpful. Yes, okay, yes, I'm looking at this right. And then just plain exposure with no medication is not really helpful. So you notice the Prozac doesn't make a huge difference, but therapy, real professional treatment, will make the biggest difference. And that most likely cognitive therapy is going to include exposure, but it's more than simply exposure. It's more than simply forcing yourself to make lots of public speeches. It's also training you like how to think better. So, for instance, somebody with an anxiety disorder is not going to stand up and say, okay, I'm nervous, but I'll get through it, I'll be okay. No, they're going to get up and they're going to say, oh, you're such an idiot, you didn't prepare enough, you're going to mess up. And that self-talk just amps up your anxiety. So a cognitive therapist would teach you how to have better self-talk, amongst many other sort of treatment tools that they would use. All right, yeah, basically talked about that. Selective mutism is another thing that can occur with high anxiety. It usually just happens in children. It could happen in adults, but it's mostly a childhood disorder where they just stop talking. Something traumatic happens, something just really, really anxiety-provoking happens to them, and they shut down and stop talking. I had a friend in high school who I think she was, parent was murdered or in front of her, something really horrible like that, and she stopped talking in 3rd grade, and up until high school she still hadn't talked. I don't know if she's talking now, but yeah, so really something super traumatic. You probably it says high comorbidity with social anxiety disorder, true, but I would also say it has a maybe not high comorbidity, but it's definitely comorbid with post-traumatic stress disorder. Okay, so then of course we have our trauma disorders, post-traumatic stress disorder and acute stress disorder. Everything starts as acute stress disorder. That means short-term stress. So you have a really bad reaction to stress. If that bad reaction continues, then it's post-traumatic stress disorder. Most people do not get PTSD after a trauma. Most people meet the criteria for PTSD for about a month and then drop. Those who continue are the ones who will get PTSD. So exposure to a trauma, this does not have to be you were exposed. You could have seen somebody else exposed. So for instance, a lot of people said for war that the aides and the people who were doing maintenance and so on, that it wasn't possible for them to get PTSD. I should specifically say the government said it wasn't possible for them to get PTSD because they weren't out on the front lines, so they weren't in danger of dying, and so therefore we don't have to give them any benefits for PTSD because they can't get it. But the truth is that you can vicariously be traumatized. You can watch TV and be traumatized. You can hear all of the other Marines coming back in and, oh, the ambush and this person died and they're covered in blood, and you can be traumatized by that. You don't have to be in the midst of this trauma in order to be traumatized. There's rates of PTSD that skyrocketed, well, not skyrocketed, but went up in people outside of New York after the 9/11 attack. I had a client who came in for therapy 3 years after the towers fell and said, for anxiety issues that was triggered by that. He couldn't stop thinking about it, and he always had anxiety about other attacks, and every time he saw a plane go by, he had anxiety. And I said, were you there? No. Did you know anyone who's there? Nope. Just saw it on TV, and now he has anxiety issues. And this is 3 years later, so definitely PTSD. So continued re-experiencing memories, nightmares, flashbacks, where all of a sudden you're there again. Avoidance, that's part of everything for anxiety. Avoid anything that stimulates you to remember that event. Numb yourself out. Reckless or self-destructive behavior, especially drinking, driving quickly, things like that. For whatever reason, that helps us to forget. Probably causes certain neurotransmitters to rise that make you feel better. Interpersonal problems, always an issue. As a matter of fact, I would not treat PTSD without treating a couple, or a family, assuming they were in that situation. Everybody needs to know how to deal with this person. And then it has to persist for more than 1 month after the trauma. If it is less than a month, then, like I said, it's acute stress disorder. All right, so not super common, but not uncommon. 7% have this in their life. 3.5% of people, period, will be diagnosed with it in any single year. The type of trauma makes a difference. The more severe it is, the more often it's happened to you. So people who have been sexually assaulted or molested at any point are likely to have that happen to them again for some reason. And so if you have experienced repeated sexual assault, you are 2 to 3 times as likely to develop PTSD. Proximity, the closer you are to the trauma, the more likely. So the client I had with the PTSD from 9/11, that's really rare for somebody that far removed from the trauma to have PTSD, but it is possible. Yeah, I think I talked about all this. Oh, okay. One of the biggest things, let me just point this out before my computer dies. Poor social support is the biggest risk factor for having PTSD. So people will go through trauma and they come home to a loving family who says, I'm so sorry this happened to you. We will do everything we can to show our love and support and to comfort you and give you what you need to get through this, to babysit your kids while you cry or sleep for the next week or whatever. Take you to doctor's appointments, whatever it is that needs to be done. We will hold your hands through it. Your risk of PTSD drops dramatically. You go home and you say, you know, Uncle Joe raped me, and they go, you're a liar. He would never do something like that. How could you say that about your own relative? And then they refuse to ever talk about it again, or maybe cut you off from the family and everybody stops talking to you. Your rate of PTSD, really high. Or your chances of getting it goes really high. So social support is the number one predictor of whether you will get it or not, whether you have PTSD or not.